Good evening, and thank you for being with us here this evening for a very special Let's Talk presentation. My name is David Sampson, and it is my honor to serve as the Managing Director of the Center for Women's Health Research, located right here on the Anschutz Medical Campus. Let's Talk is a collaborative educational series that brings together the University of Colorado Hospital, including the WISH Integrative Services in Health, also known as the WISH Clinic, and the Center for Women's Health Research located within the School of Medicine. Here with us tonight is Dr. Judy Regensteiner, who is not only the director of the center, but it's one of its founding members as well. So we welcome Judy Regensteiner, whose thumbprint is all over the Let's Talk program, as is Chiara Delmonico, also here tonight, with other folks on leadership from the hospital. The basic premise of Let's Talk is to provide content and education that empowers women to navigate and take control of their health. And men, listen up, because this affects us too. In presenting evidence-based health information, we are empowering you to make informed choices about your health and assist you in the health needs of your family members. As I said, this evening's presentation is very special. Having worked in hospice and palliative care for 16 years in Chicago before I came to Denver, I have come to appreciate the value of conversations involving advanced directives, palliative care, and caregiving. It is a subject that, if it already hasn't done so, will affect each and every person in this room at some point. Ours is a culture where we are pretty adept at avoiding the conversation of terminality. Perhaps we think we are going to live forever. I think Woody Allen sums it up best when he says, "I'm not afraid of death. I just don't want to be there when it happens." Tonight you will hear from those who are leading the way in palliative care, advanced directives, and caregiving, and you will leave here this evening with educational content and materials that will provide you with the access to resources that you will one day need, whether it's for yourself or someone that you love and care for. Without further ado, I would like to draw your attention to our center stage for a role play by our palliative care team. So I'm going to take seats. In tonight's family meeting role play, Harry,
you're going to be in the middle.
Stage right. Harry's on the right. Will play an advanced practice nurse, and Aaron will play a social worker. Both are members of an inpatient palliative care team. This is what they call typecasting, because Harry is, in fact, an advanced practice nurse, and Aaron is, in fact, a licensed clinical social worker. Harry and Aaron were asked by the primary care team to meet with patient Mr. Lee, who is a 72-year-old gentleman admitted for aspiration pneumonia and weakness, and who has been experiencing physical and cognitive decline at home. When approached by the care team just minutes earlier, Mr. Lee told the team that he is tired and he has given permission for his adult daughter, Jeannie, to hear from Aaron and from Harry. So here's our adult daughter. Harry, Aaron, and Jeannie agree to meet in a nearby conference room, which is where we are joining them now.
Thanks for having us meet with you today, Jeannie. Just to review, my name is Harry Brackett. I'm an advanced practice nurse with a team called Palliative Care.
My name's Erin. I'm the social worker on the palliative care team. It's nice to meet you.
It's nice meeting you. I'm Jeannie. I'm the daughter.
So, Jeannie, Palliative Care is a special medical team, and we're part of it. And we see people who have serious illnesses. And we do a couple things. We help with people's pain and symptoms so they can have better quality of life. And the other big thing we do is we learn more about our patients and families and their values and priorities and try to match those values to what's realistic medically, into next steps.
Okay.
We help with decisions. Most importantly, we hopefully add an extra layer of support for you.
Okay.
You know, Erin and I looked over the chart and we talked to your dad's doctors. So we know a little bit about what's going on with Dad. But you know, I want to pause there and talk about that in a little bit. You know, what I'd really like to know and what's not in the chart at all is about Mr. Lee. Can you tell us a little bit about him?
Sure. He's very proud. He's a very proud and independent man. He's very proud of his independence and his health and or not having been sick until today, and his work ethic and his accomplishments. He has 7 brothers and sisters. He's the only one that went to college, and he actually pursued a PhD also. So he really values education and family. So, and he's very proud of his family. He's just a very proud and independent person. Yeah.
What kind of work did he do?
He was an electrical engineer.
Oh, okay.
So he loved math and helping us with our math problems, and he's very regimented. He likes his days structured and being on time.
Okay.
So if he knew he was going on a trip back to Korea in October, everything would be packed by September 1st.
So he's a planner.
He's a planner.
Okay.
He supported my mom when she pursued her master's and PhD while we were growing up. And so he was actually the one that got dinner on the table. And he always had dinner on the table between 4:55 and 5 p.m. every day growing up, yeah.
It's not a very big range.
No, well, he's a regimented person. Yeah.
You said we, so are there other siblings besides?
My sister,
Okay.
Annie, and I, we live in the area, so we take turns dropping in on him. Yeah.
So what kinds of things does he do now for fun, and how does he spend his days?
He loves Fox News. He's like 24/7.
Okay.
He's 110% Republican. He and my sister don't talk about that.
Okay.
He loves asking about his grandchildren's grades and what they're learning at school, and I have to keep telling him, no, they're not learning multiplication. He's just in 1st grade. He used to like cooking. He doesn't do that as much now, and he used to really love going to the grocery store and the mall and finding like things on discount and on sale and getting them and showing them to us. Like, I saved 20%. I saved 70%. Yeah.
He's a bargain hunter.
Yeah.
Nice.
Yeah.
So what have things been like more recently? You said he used to. How have things been now?
Things are okay. I mean, reason why he can't go to the grocery store as much is because we've had to take away his keys and cars. He got lost a few times, which was okay. He found his way back, but the last time his grandson was in the car. So
That was scary.
Yeah, that was really scary.
Yeah.
He's doing a better job of using his walker,
Okay.
like remembering to use it. I mean, it's the pride thing, but he fell a couple times. He didn't hurt himself. So that's going okay. I have to admit, like, it's sort of funny and not funny at the same time. Like Annie and I, when we drop in on him, you never know what we'll find in the fridge. Like one time was a wristwatch. Annie found a baseball cap.
Okay.
And I think last week I found a remote control. So we laugh about it, we joke about it. Yeah, and then I know one time I got a panicked call from my husband because Annie and I were working. He dropped by, and there was this foul odor in the kitchen. Couldn't figure out where it was coming from, and he opened the oven door, and apparently there was like a pot roast that had been there for a while, and we didn't think he was cooking, so that was... I've been thinking about that for a little while, but we haven't had an incident like that since, so we're okay.
How have you been coping with just the changes of how your dad used to be and things that are happening now?
We just take it day by day and we don't talk about it much. We just take each incident at a time and just try to do our best. Yeah. It's been okay so far. With my sister and I, like my sister and I talk about it, and it helps that we plan how we're going to take turns checking in on him.
Right. What do you think about all these changes happening?
Well, we were doing okay, and then he had this pneumonia, which was a shock to us because he never gets sick. Thankfully, the doctors say he's doing much better. He's doing really well. He hasn't had a fever in a couple days, and his white count is like 8, which the nurses say is normal. So he's doing much better.
Good. I'm glad.
I don't know when they're going to allow him to eat again, and that worries me because I think he needs his nutrition. But I guess he was aspirating, which means his swallowing muscles are weak, so when he swallows, things going down the wrong pipe.
That's right.
Okay. So.
How long has that been happening, Jeannie?
This is the first time I've heard about it. Yeah. Okay. I hope it goes away. Yeah.
What else are you hoping for?
I just hope this doesn't happen again. I know things can go back to where it was like 3 years ago, but I hope things can go back to how it was like a month ago, where everything is stable, and this was just a minor setback. Yeah.
Are there things that worry you?
I guess everything I just mentioned out loud. Like him falling and hurting himself. And finding that pot roast made me really worried.
Absolutely. Because it's so out of character, right?
Right. Yeah. And just being able to honor him so that, because he is independent, he is proud. Yeah. So, yeah. That's,
Jeannie, I'm wondering, what have the doctors been telling you about what's going on with Dad?
Well, they say he might be able to be discharged soon. So they say maybe to rehab first and then home, but they say he's doing a lot better. Yeah.
I'm glad. Have the doctors in the hospital talked to you about just what's going on with his thinking and his weakness and just the changes of his swallowing? Anything like that?
No, I mean, about a year ago, Dr. Burt, his PCP, said he had like a mild cognitive deficit, and I said, is that dementia? And he said it might be early dementia, but we'll just monitor him, and Dad's been stable, so we didn't really think anything of it. Right. And I think one of the doctors mentioned that, like offhand, but he didn't really go into it, so I thought maybe that wasn't really a big deal.
Jeannie, it sure sounds like with everything that you're describing, with his weakness over time and now him having to use a cane and changes in the way he swallows, and especially changes in the way that cognition and the way he's thinking and sometimes not thinking clearly, like with the pot roast and leaving things in the refrigerator, those are all kind of early to moderate signs of dementia. Is that a scary word? Yeah.
I'm worried it means things are going to be prolonged before he passes away. That's what that means to me.
You're scared things are going to get harder.
and it'll be harder to honor him and his dignity. Yeah.
We can talk about ways that we can make sure that his dignity is always honored, and that we can access resources that can help you and your sister to maintain that dignity for him. Okay.
Okay. Yeah.
You know, I'm wondering now, Jeannie, have you and your sister ever talked to your dad about, you know, if he has fuzzier days and days that he's not thinking as clearly or he gets sick again, who is the person that makes medical decisions for him on his behalf?
We never, I guess we would make that decision together as a family. Yeah, we usually talk things over.
The state of Colorado is a little funny where we actually like to have it put down in writing on who is his healthcare advocate. Doesn't mean that you can't all make decisions together as a family, but we just need to know legally who we should go talk to.
Okay.
So I'm wondering if it would be helpful and if we could take care of that, because it's important that we have it while he's in the hospital, and go check in with him now and find out who we should put down in writing to support him.
Do I need to bring a notary or?
Nope, it's a simple piece of paper. It's just one page, and it just needs his signature.
Okay.
So we can take care of that today.
Okay, yeah, that would be good to find out. Yeah, yeah.
And today, since he's having a good day, I bet he could tell us pretty clearly who that would be.
Yeah, yeah. Okay.
Do you have any questions about just what to expect, or?
Do you think we could meet again later with my sister so that we could talk about what to do next and about those resources you were talking about? This was like a really hard conversation, and I think it might be nicer if she was also a part of it. Yeah, I really appreciate it. I can't believe we haven't really thought about any of this. Like looking ahead, things have been pretty stable.
You know, many people don't think ahead like this, so you're not alone. But I'm glad we're doing it now.
Yeah.
And it was such a pleasure learning about your dad and how proud he is. And I hope and I know that we can maintain his dignity.
Thank you.
Mm-hmm. We'll teach you a lot about what to expect and what this aspiration means and just what's going on with his health.
Okay.
We'll do that with your sister Annie.
Okay.
Okay?
Thank you.
Okay.
Before we go and visit with your dad, is there anything else you were hoping that we would talk about now?
No, I think we covered a lot. I didn't know what we were going to talk about, so I was really very, very nervous. To be honest, I thought we were going to just talk about hospice and end of life, but this was very important. Thank you. Yeah.
A lot of people think that palliative care is hospice, and really hospice is kind of an extension of palliative care with a lot more services and resources, and that's something that we can talk about and kind of make not so scary later on, but right now we really just wanted to get to know about your dad.
Okay. Yes. Thank you. Yeah.
Okay.
All right. Can we walk you back to the room?
Yes.
Okay.
Okay.
Great.
We thought we'd start on a light note. How great are they? This trio actually probably has this conversation several times a day. And I think it's fair to say that many of us can see ourselves at either end of that conversation. I wanted to point out that the person playing adult daughter number 1 is actually Dr. Jeannie Lee, who is part of the palliative care team here at UCH, and so they did a wonderful job. It is, yes, definitely. It is my privilege right now to introduce Dr. Jean Kuttner. Dr. Kuttner is the Chief Medical Officer here at the University of Colorado Hospital, and while I can spend a lot of time talking about her many degrees, awards, and accomplishments, what will matter most to all of us in this room is that Dr. Kuttner is extremely gifted at helping patients and their families navigate the complexities of palliative care. She is gifted in her ability to present information in a very understandable manner, as you will soon come to learn. Denver is in good hands with competent and compassionate physicians and practitioners like Dr. Kuttner. So here to present palliative care, what it is and how to access it, please help me welcome Dr. Jean Kuttner.
Thank you, David. It is a pleasure to be here. It sounds like you can hear. Back row, you can hear? Excellent. And thank you all for coming out tonight. I'll welcome you with my Chief Medical Officer hat on to University of Colorado Hospital. Thank you for coming to our facility. I get the good fortune of spending most of my days here somewhere on this campus. But today, for this evening, I'll be, as David said, talking with you about palliative care. And I think, we have the good fortune also here on this campus to take advantage of excellent clinicians, as you just saw when I'm on clinical service, as I was over the weekend for palliative care. I get to hang out with these wonderfully, highly talented clinicians. We also get the privilege of educating that next generation so that they know what palliative care is, nurses, physicians, PAs, advanced practice nurses, et cetera, so that we get that word out into the community and get that expertise out into the community, and we have some fabulous educators here. And we also get to advance the science. We get to move forward our understanding so that when we are providing palliative care to you, your loved ones, your neighbors, that we know that we are providing you the best level care because we are deep in the midst of the science of that. And I think I actually just described my day. I think today I was on a research call, did clinical care, and was teaching. So welcome to academics. So I get the advantage of kind of laying the ground here for the next couple of speakers. So before this evening, who had heard of palliative care? I love it. You can tell we're in 2015. The way I can tell that is because if I had asked that question even 5 years ago, it would have been maybe a half to a third of those that raised their hands. So I am thrilled that that many people raised their hands. Okay, how many could you explain it to somebody across the dinner table? Aha, okay. After tonight, you will be able to explain it to somebody across the dinner table. So let me start by telling you about a patient. This is a patient that I had the good fortune to know. I actually saw him in my general medicine practice, which is at our Lowry Internal Medicine Clinic. This is a 75-year-old man who was really doing quite well, and then he was diagnosed with pancreatic cancer. He was living in the East Coast at the time, received chemotherapy, and unfortunately did very poorly with the chemotherapy. Ended up in the hospital for about a week and literally got out of the hospital, moved to Colorado. Why? To be near his adult daughter. How many of you are adult daughters? You wondered how this was about women's health, but now you know. So he came to me in my general medicine clinic because I had palliative care expertise. At the time, this was several years ago, we did not have the advantage of having an outpatient palliative care clinic. We now have an outpatient palliative care clinic. We actually have two, one in our cancer center and one in neurology. So he probably would have gone there, but we didn't at the time. He came to see me, and the question is now, what do I do? So I will come back to that. So keep him in mind. 75-year-old man, new diagnosis, pancreatic cancer, just moved to town. So there's good data, some of it of the research conducted by folks here at University of Colorado, as well as our colleagues nationally and internationally, about what people want near the end of life. There's probably no surprises on here. If you think about yourself, your loved ones, what would you want if you were seriously ill? You heard some of it in the role play that occurred. People want their symptoms, especially pain, to be well controlled. They don't want a prolonged dying process. There's a real sense of wanting to achieve a sense of control in a setting that often feels very out of control. Often people are very worried about being a burden on their family. I'm betting if Mr. Lee was able to tell us, I bet he would be worried about being a burden on his family. I know my patient was. And people at the time of serious illness want that opportunity to strengthen their relationships with their loved ones. Any surprises here? No, okay. So what is palliative care about? You heard a little bit. Palliative care is really all about enhancing quality of life. The definition that I have up here came out of some national polling that was done by the Center to Advance Palliative Care, as well as the American Cancer Society Cancer Action Network. And it was written in language that people felt resonated through national polling. And this is often language that we use when we're seeing patients and families to explain what is this thing called palliative care that has just come into their lives. So we focus on people with serious illness. Notice there's not a particular diagnosis there, but serious illness. The focus is on improving quality of life, however that individual defines quality of life. It is provided by an interdisciplinary team. You saw part of that today. You saw our advanced practice nurse and social worker. The additional members of our team here as physicians as well as chaplains. We also have volunteers. I know at least one of our palliative care volunteers is here tonight. Over there, say hi. So we work together as an interdisciplinary team to meet the needs of the patient and the family, providing an added layer of support, working along with the other treating physicians. Key in this last bullet, palliative care is relevant at any age, for any diagnosis, and at any stage of a serious illness, from very first diagnosis all the way through that person's illness trajectory. And palliative care walks hand in hand with the other disease treatments. Okay, everybody got that memorized? So next time you're at a dinner party, I don't know, say last night, and somebody says, what is palliative care? You got it? Excellent. So what are those components of palliative care? You heard Aaron talk about hospice being one way of delivering palliative care. That is often a question that we get. Well, what's the difference? The way to think about it is that as palliative care is the overall approach, focusing on people with serious illness, quality of life, extra layer of support, walking hand in hand with you, addressing the topics that are here on this figure, decision-making, advanced directives, things you're going to hear a bit about later, support for the family, pain and symptom management, helping with the goals of care. You heard a little bit of that discussion in the role play, and helping with communication. So if you think about, and I'll show you a figure in a minute, this is really the other way to say it. This is what palliative care focuses on. It helps people live each day, no matter how many days they have, to the fullest. So people often think about it this way. They often think, well, you can get all this aggressive stuff, and then at some point, as one of my favorite palliative care colleagues says, you get thrown over the wall to hospice. That is what we're trying to avoid. What we're trying to get to, and the focus here, is that if you take from over here at the time that you get a serious diagnosis along that disease trajectory, even at that time of that very first diagnosis, there are palliative care needs. There's whatever symptoms first brought you to the doctor. There's the distress of hearing that you now have a serious illness. There's the planning for the future. And at the same time as getting those treatments that may be addressing the disease, addressing those palliative care needs. And if at some point, if your disease progresses, then you become eligible for hospice care, there's that nice smooth handoff because your needs have already been addressed, and then support for the family following that. So there's kind of a neater way or a combined picture of showing that at the time of diagnosis, addressing the palliative care needs while there's disease-directed therapies going on, like chemotherapy or heart failure therapies or whatever, and addressing the various needs over time, which a disease course changes over time for each individual and allows us to work hand in hand over that time period. Is that clear? Excellent. So the focus is really on integrating with that ongoing disease care, managing symptoms that may be causing suffering. There's actually some great data that's coming out that people who get palliative care have lower symptoms, so they're actually able to participate in whatever their disease-directed therapy is. Focusing on communication, I think you saw a beautiful example of this in the role play that you just saw. Understanding who is this person? Sure, they have a serious illness, but they're a person. Who is this person? What are their values? What are their goals? What is important to them? Helping them, given who they are as a person, what are their options? How do they balance for them personally the risks of potential treatments, the benefits of potential treatments, and the burdens of those treatments? And then what we help families and patients do is create a plan, and then a backup plan, and then a backup plan, so that the care that they're receiving is a good fit with who they are as a person. So there's plenty of data now, both our own data as well as data from across the country and internationally, that shows that palliative care is associated with all these good outcomes. Remember the slide at the beginning where we all agreed this is what people want? Palliative care with good research is now showing this is what it gets for people. Decreased symptoms, helping with those goals, improving quality of life, increasing both patient and family satisfaction with care, actually helping the providers as well. Imagine, some of our nurses in the ICU here, they see a lot of sickness day after day, helping to support them, helping patients, as I said, complete their treatments because we're addressing their symptoms and their distress, and then enhancing the value of what we provide in healthcare. So when we talk about value in healthcare, it's talked about higher quality at a lower cost, and palliative care is really meeting those needs. All these high quality things that I just mentioned, and also good data now coming out as well, that people who receive palliative care actually have lower costs of healthcare. So then you say, well, who really needs palliative care? Really thinking about from a broad variety. People who have a serious illness who maybe they're suffering because of physical or emotional symptoms. Those people maybe are not stable. They keep coming, we have a lovely emergency department. What direction am I? Over here. They keep coming to the emergency department, or they're just not doing well at home. Maybe they're not less able to care for themselves, the scenario that you saw in the role play, or just those people who have a serious illness who want more information. They're a planner. You heard Mr. Lee was a planner. People who are planners, they want to know what are my options, what's going to happen next, how do I plan for my future now that I have a serious illness. So then I often get the question, well, how do I get it? The other question is how it's paid for, and I can answer that too. No, I didn't make a slide on that, but how do I get it? Where do I find this thing? Sounds fantastic, right? Who wouldn't want it? I will tell you up front that the most access to palliative care is actually in hospital settings. Currently, we still have a gap in the home-based or clinic-based care. We here are working on addressing that, and there's a number of initiatives here in Colorado as well. So in the hospital setting, as you saw, there's the opportunity to get palliative care consultation. That's what we have here in this hospital. We actually started our palliative care consultation service back in 2000. I think we were either the first or one of the first in the state, and where we bring our whole team to meet with the patient and family. There are some hospitals that actually have a separate palliative care unit. We have palliative care beds here, but they're not separate into a separate unit. And then there's some hospitals that actually have hospice beds that are inside their hospital. In the outpatient setting or outside of the hospital, recognizing that most of us even people with serious illness, spend their time outside of a hospital. Like I said, it's a little harder to access, but there are a number of our community-based agencies that do provide home-based palliative care. As I mentioned, we now have outpatient clinics here in our cancer center and in neurology, and there's a few other locations across town that have an outpatient palliative care clinic. The VA, for example, Kaiser, for example, actually have very strong outpatient clinics. Denver Health now has an outpatient palliative care clinic. People can get palliative care in the nursing home. So if we're discharging somebody, let's say Mr. Lee ended up going to a nursing home when he got discharged, he could get palliative care at the same time. And then, as I mentioned, hospice is one way of accessing palliative care because of the way it's reimbursed here in the US. Most hospice benefits can only become activated when somebody has a 6-month or less life expectancy and they're no longer pursuing treatments to treat the underlying disease. So it's a very good way of getting, as I think Erin said in the role play, a much broader set of services. Its advantage is it's actually a defined benefit. It's a Medicare benefit, and most private insurances also cover hospice. So the question of then, how is palliative care covered? Not as well, and not as a broad range of services, especially in the community-based setting. Here in the hospital, for example, when I go see a patient, I can bill insurance just the way I do on any other way I see a patient as a physician, as can our advanced practice nurses, and then the hospital supports the costs of the rest of our team, the chaplain and the social worker and all that. So sort of covered by insurance depending on where you are, and we can address that more in questions and answers if you want. So how are we doing? So sounds like something we all should have access to, right? That was very quiet, right? Yes. Okay, thank you. It's late in the day. We need a little enthusiasm here. So the Center to Advance Palliative Care puts out every several year report on access to palliative care at U.S. hospitals. This focuses on hospitals that are 50 beds or greater and tells us how we're doing. And I'll spend a little time explaining this. The good news on this is we're getting better. There's much better access to palliative care in the U.S. The bad news is that we don't all get an A grade yet. So let me orient you here. This from your left to your right. This is 2008, 2011, 2015. Okay, got the years? And then the colors, and I apologize for those of you that are colorblind, so I'm going to show you where they are on the wheel. The top of the wheel, which is this dark blue, is a grade of A. And then going around to your right, the lighter blue is a grade of B. This medium color blue is a grade of C. The next one after that, working our way clockwise, is a D, followed by an F in the red. So you can see, if you just say, let's go very simple, there were a number of Fs in 2008, no Fs in 2015. The sliver of states that got an A grade for access to palliative care in 2008 was pretty little. It's pretty big in 2015. Progress. Good news. All right, how do you think we're doing in Colorado? What grade? Those of you that looked ahead, no fair. And my team can't answer. A, B, A, B, A, B, C? Well, we know it's not an F because there was no Fs in 2015. So I'm glad nobody said F. We are at a B. We've been at a B. We need to be at an A next time. So what this is saying is as about 76% of hospitals greater than 50 beds in Colorado have a palliative care service. So you have a pretty good chance in Colorado, if you get hospitalized, if your loved one gets hospitalized, that you will have access to palliative care. It's not 100%, and it's a much lower percent in the smaller hospitals out in our rural areas. And for those of you that are noticing the colors there, the color scheme follows, so there's definitely some states in which you don't really want to be having serious illness. There's probably other reasons you don't want to be there, but that's another whole talk. We're not talking politics, just palliative care. So there's also some differences in whether hospitals have palliative care by both their size as well as their for-profit or nonprofit status. What I actually think is most interesting here is if you look at the hospital size here. So this is from your left to your right. The darker blue is public hospitals. The medium color blue is nonprofit hospitals. And then the black, I guess that is for-profit hospitals. And what you see is as you get to higher bed size, this is less than 150 beds, 150 to 300 beds, and 300 or more beds, you're more likely to have a palliative care service. You're also more likely to have a palliative care service at a nonprofit or a public hospital. The types of things that are important to our hospital leadership too is that if you look at the honor roll of the top hospitals, both adult hospitals and children's hospitals in the US, 100% of those hospitals have palliative care. Okay, so let me come back to my patient. So what happened? So my first meeting with him, which like I said was over at our Lowry clinic, it was the patient and his wife who had moved out here with him, also in her 70s, the proverbial adult daughter, the daughter's husband, and then their daughter, who's an adult. And what the patient told me, so what do? I want to find out what's important to him. He said he wanted to feel better. And this is a very medical term here, he said, I feel like crap. So his goal was to feel better. He was on many medications. He just felt awful. He was fatigued. He was weak. He basically was saying, make me feel better. So my assessment of him really followed a lot of what you saw in the scenario. It was 90 minutes instead of 17 minutes. But first of all, what's his understanding of his illness so far and the treatments that he's received? To make sure we're on the same page. Does he have the same understanding of his illness as I do? What are his symptoms? What are his quality of life? What are his sources of support, both social support as well as spiritual support? How is he coping? How is his family coping? And what are his goals? So there's kind of a set of things to find out from him. So what did I find out? He wanted to feel better. He wanted to get better function. He wanted to have a better quality of life, no surprise. And also no surprise, he wanted to live as long as possible. Now, are these goals that are not congruent with each other? These are goals that are congruent with each other. He did tell me that he did not want any more treatment for his pancreatic cancer if it was going to make him feel as badly as it did. However, he would think about therapy for his pancreatic cancer if he would feel better. So what did I do? I called up our pancreatic cancer specialist and said, hi, I've got this patient. Let's work together. You take care of giving him options on what might benefit him from a pancreatic cancer perspective. I'll work hand in hand with you on making sure that his symptoms are controlled and that he's supported. So that's what he did. He met with our pancreatic cancer specialist, and she worked with him on identifying treatments that would balance those risk, benefits, and burdens that we talked about for a focus on controlling his disease while not harming him. I adjusted his medications to address his bothersome symptoms. I also connected him with community-based palliative care, and we got his advance directive done, Erin, on that first visit. Erin's our advance directives police, so you'll soon hear. She makes sure we get those advance directives done. But yes, we got his advance directives done using actually that 5 wishes form that you have in your packet, by the way. So what happened? So remember, new diagnosis of pancreatic cancer, 22 months. He had 22 months of very high quality of life. He received chemotherapy and radiation. He had some initial shrinkage of his tumors. He felt much better. We got nutrition support for him, physical therapy support, got integrative medicine involved with him, psychological support, so that he did quite well. He and his family actually had a lovely 22 months here living in Denver together. About 23 and a half months, he then had progression of his disease, and he did die. He died with home hospice, which was an easy handoff because he had been getting home-based palliative care, transitioned to home hospice. And speaking with his wife after he died, they just felt very supported. I mean, she was appropriately sad, but they were realistic the whole time, and he was able to have that quality of life, showing how we can work hand in hand between palliative care and, in this case, cancer care. I think I already said that. So my goal and all of our goals here is to achieve for anybody with serious illness what my patient was able to have. He was sort of somewhat lucky in that he stumbled into seeing me in my clinic. Our goal, both with our specialty level palliative care and as we're educating and advancing the science, is to make sure that everybody can have that kind of experience. So you may wonder, where can I get more information? You may be thinking. So for those of you that like a little light reading, I had the good fortune of serving on the Institute of Medicine panel that came out with this report that was published just over a year ago, September of 2014. It was an update to a couple of earlier Institute of Medicine reports that looked at where we are in terms of the state of care for people with serious illness in America, and a series of recommendations. Like I said, if you want a little light reading, the total report is about 565 pages. I think only those of us on the committee actually have read the whole 565 pages. Yeah, anybody else read the whole 560? Anyway, that said, there is a wonderful executive summary. There's a couple of really short summaries on the Institute of Medicine website. There's also some slide decks and all if you want to get the word out about it. And actually, I'm doing some kind of interview coming up about the findings of it. So this is on the Institute of Medicine website, iom.edu, or you can just Google IOM end of life, you will find it, or IOM dying in America, you will find it. All right, how many people have read this book? Wow, look at that. Okay, those of you that don't, it came out just about a year ago. This can be your Christmas week reading. It was a lot of our Christmas week reading last year. Atul Gawande is actually a surgeon at one of the Harvard hospitals, and he writes eloquently in this book about his own experiences as a surgeon, as well as, in this case, an adult son, as well as bringing in the evidence of care for older adults in America, as well as care for people with serious illness. It is eloquently written, and I don't get any royalties from it, but I highly recommend it. And for those of you that would prefer to get your information from the web, this website, getpalliativecare.org, has information both about what is palliative care, as well as where to find it, as well as, so there's the how to get it, and underneath the how to get it button, how to talk to your doctor about it. There's some wonderful tips in here about, hey, my doctor's not bringing this up. Maybe I should bring this up to them. Some wonderful tips in here about things to talk to your doctor about in the setting of serious illness. Highly recommend that, because even those of us that do this for a living forget sometimes. I was just whispered to Ben as I was watching the scenario. I came rushing over here from seeing patients at Lowry and saw a patient and her husband. She's got actually early stage dementia. Totally missed the opportunity, sorry Erin, to do advanced directives today. And I realized as I was watching the scenario, the husband actually said, how long will these medications work? I missed the cue. I was too worried about getting here on time. Anyway, so I need to follow up on that. I think the husband was trying to talk to me. I missed it. I will do it next time. I told Ben I haven't done my clinic notes yet, so I'll write myself a reminder in my note. So I will end with this slide, which is a quote from Dame Cicely Saunders, who was really the founder of hospice care from St. Christopher's Hospice in London. And I think this really just embodies what it is that we are working, what keeps us going every day as we care for patients. So thank you for your time, and I think you will enjoy the next talk, and we'll get questions later.
We're surrounded by brilliance here. Thank you, Dr. Kuttner. I have it on good authority that we are either on or around the celebration of a birthday, perhaps? All right, well, yes, if you want to talk the importance of birthdays, talk to a palliative care doc, so happy birthday. So there is a saying in some circles that talking about death isn't going to kill ya. I subscribe to this school of thought, and I believe our next speaker does too. There is something to be said about a life well lived, and part of this can include how we die. Here to talk about the importance of advanced directives is Erin Rosenberg. Of Erin's many gifts is her ability to facilitate conversations about advanced directives, what kind of treatment I do or do not want, how I want to be remembered, who I choose as my healthcare power of attorney to make decisions on my behalf if I become unable to speak for myself. Erin has earned the distinction of being an advanced certified hospice and palliative care social worker, and we will all benefit from her presentation on advanced directives. Please help me welcome her.
So, as you all just heard, I'm a social worker. And social workers are trained to empower their patients to be able to regain sense of control in what can feel like an uncontrollable situation. Advanced care planning, to me, is the ultimate empowerment tool. It is addressing that elephant in the room. It's having that hard-to-have conversation that we all acknowledge should happen. It's the act of how we plan for a medical future. It is how we explore our values and goals. It's how we determine a surrogate decision maker who actually ends up becoming your legal healthcare advocate. And it's how we complete those advanced directives. So my goal by the end of this talk is for you all to understand why having this conversation is so important and that this is no longer a conversation to postpone. So what are these advanced directives you keep hearing about, and how can advanced care planning help facilitate them? It's just directions given by you that express your wishes. It's a legal document that expresses what you would want for your health care if you're ever not able to personally express it yourself. It's a way that you help plan for your healthcare future. And it's a communication tool that allows shared decision-making about end-of-life decisions to be clear. So, I'm going to talk about the first 3 of these advanced directives tonight. First one's a medical durable power of attorney, also known as a MDPOA. And I'll also call it a medical power of attorney. They're all the same. A living will, and the 5 wishes. By completing these, you're going to make sure your wishes are known and honored, that your decision maker has the burden lifted on them because they understand what you're hoping for, and that you have legally completed documents. So here's a question for all of you. In the state of Colorado, who becomes the default decision maker on once we have it, if they can no longer make decisions for themselves? Any guesses? I'm hearing C. E. Hearing all letters, okay. The answer is E. So it's actually any of the above. The state of Colorado does not have a default hierarchy decision maker, which means if you have not put down in writing who you want to represent you, it is not automatically your husband or your child. State of Colorado says that we have to gather all interested parties to determine who should be your spokesperson. And I'll talk about the interested parties in a second. But really what this means, and what I hope you all get, is that this is something every person should have. If you are over the age of 18 and you live in Colorado, you need a medical power of attorney. This is not a piece of paper for the sick or the terminally ill. This is the way that you ensure you are always in control of your health care. But if for some reason that opportunity was missed and you didn't put down in writing who your medical power of attorney should be, the state of Colorado says we have to gather anyone who is interested in your care to come and determine who should be your spokesperson. Interested parties could be your spouse, your ex-spouse, your child, your neighbor, your boss, your bartender, really anyone. I found myself in a conference room once with a family on behalf of a gentleman who came to this hospital and was not able to express his own opinions. Sitting in a room with an ex-wife, an adult child, a neighbor, and a bartender. And ultimately, it was actually decided that the bartender was the appropriate medical proxy. This was because he remembered having conversations with this patient when Terry Schiavo's case was going on and saying, I wouldn't ever want to be like that if I found myself in that situation. His ex-wife and child had never heard that dialogue. And so although we may have thought the child would have made sense, the bartender became the medical proxy. But as you can imagine, gathering all these people takes a lot of time and causes a lot of stress for your loved ones. If for some reason not all interested parties agree, because that never happens, or an interested party is not available and doesn't show up, what we have to do is we have to take this to the courts. And we need a judge to appoint a state-appointed guardian to become the medical proxy decision maker. As you can imagine, that takes more time. It typically is a month's, if not longer, process. So now that you all understand why it's so important that we have a medical power of attorney, here's how you figure out who you should appoint. You just ask yourself, like you saw in the role play, if you ever get so sick or fuzzy and you can't make decisions for yourself, who would you want to do that for you on your behalf? Thinking of the person is the first step, but actually putting it down in writing and dating it is the second. Before you think of that person, though, I really want to make sure that they meet the following criteria. They need to be 18 years of age or older. They need to be mentally able. And I say that, and that sounds like a no-brainer, but we have these adorable couples that have been married for 50 years, and the wife did her homework, and she appointed her husband medical power of attorney, and now that husband's starting to show some signs of early dementia. Now, no longer does he make sense to be her medical power of attorney. They need to be accessible, right? Which means they need to possibly have a cell phone or at least keep the phone on. We had a patient whose daughter was his MDPOA, and she worked for Department of Corrections. So 12 hours a day, her cell phone was shut off, and we couldn't get a hold of her. So that was not the ideal medical power of attorney. They need to be willing. This is not something that you assign the child you love most or to show affection. This is a job and a responsibility. The person you pick needs to be comfortable talking to doctors and be willing to take on this task. And they need to know and understand what your wishes are. The state of Colorado, although we have that funny law about interested party, we make it really easy to get this done. You guys were all given this in your handout. You'll find the form for medical power of attorney in the last page, and it just needs your name, the persons you've identified, and your signature, and it's legal. So, another question for you all. Where do you think most people state that they prefer to die? Yes, you're right. When surveyed, most Americans express that they prefer to die at home. Yet in reality, we see that most are dying in institutional settings. In a 2013 study of 343 patients, we learned that 75% of patients said that they wanted to die at home. But in reality, of the ones that died, only 37% were able to achieve that goal. That meant 66% of the people that died were dying elsewhere. So what we see is that people's desires are not matching up with the reality of what's happening. In a 2012 study, we learned that 75% of people that had these advanced care planning conversations achieved their desired place of death. We know that advanced care planning helps with the reduction of hospital days and the reality of where your end-of-life preferences are. So, what should you be telling your medical power of attorney once you've actually appointed them? They should understand who you are and what's important, how you define quality of life. When I sat down with my husband, because he appointed him my medical power of attorney, I said, you know that I live to eat, and I like to eat by mouth. And I'm social, and I like to talk, and I like to be outside and active if it's warm out. And he stared at me and said, yeah, I know all these things. And I said, I need you to keep that in mind, because that's my quality of life. That is my baseline. And if there's ever a situation where I am sick and I'm in the hospital, and there might not be a chance that I can go back to eating by mouth, that I can't be social, that I can't be independent, then I need you to understand my quality of life is in jeopardy, and we need to ask more questions. So it's really important that your medical power of attorney understands what your line in the sand is. And once you've had this conversation and you discover your preferences, you can put them down into a living will. So a living will is a document where we express what type of interventions we would want if we're ever so sick. This could be living on machines or being on artificial nutrition, life support. Most living wills require either to be notarized or witnessed to become legal. And a lot of living wills don't include the language of a medical power of attorney. And I raise this up because I want to make sure if some of you have gone to the lawyer and you've worked out and we've taken care of the living will, they don't always appoint a medical power of attorney. And so I really encourage you to go home and check yours, because if you don't see an MDPOA specifically listed, you still do not have one. When you're having this living will conversation, you want to make sure you're talking about with your medical power of attorney, what type of interventions would you want? What are the goals of those interventions? How long would you want to try that? Another form of a living will that I like is 5 wishes, and you also have that in your handout. And 5 Wish was actually created by a lawyer who took a sabbatical with Mother Teresa in Calcutta, India. And while he was there, he was witnessing people dying with peace and dignity, and he didn't understand why, because there was no Western machines or medicine. And what he realized was because the people that were caring for these patients knew them as people and not a diagnosis in a bed. So he came back and he created 5 Wishes. And it's a legal document, but it's a way to kind of create more of the person out of the living will. So the first wish is the wish that I've been driving home tonight. Who do you want to be your decision maker? That's the medical power of attorney. The second wish is more of the formal living will, as in what type of interventions would you want. The third, fourth, and fifth wish are the ones that I love because that's where the personality comes out. They give you suggestions, but it also gives you space to write in what you would think. So for question number 3, what makes you comfortable? Do you want a warm washcloth on your forehead if you have a fever? Do you like to be massaged? I wrote in mine, don't tuck the sheets in around my feet. I can't imagine being weak in bed with tight sheets. So think about what makes you personally comfortable. The fourth one is, how do you want people to treat you? My husband crossed out that he wants religious readings read to him and wrote in he wants the New York Times. When I used to work hospice care, sometimes I would meet patients that were no longer responsive. And so I'm a touchy-feely person. I would go in, I would sit down, and I'd hold their hand and just be with them. But one time I was meeting a new patient, I was flipping through her chart, and I saw a big, bold X over the I want my hand held and to be touched. I was so grateful that she did that, because I would have completely violated her space if I had just gone in there and held her hand. And the fifth wish is, what do you want your loved ones to know? This is where you can talk about funeral plans or just your wishes or thoughts that you want to make sure your family understands about you. This document also needs to be either witnessed or notarized to become legal. But really what the most important thing is the conversation that comes behind the completion of this paperwork. So once you've done all of this, make copies. You keep the original. You give the copies to your medical power of attorney. You give the copies to your healthcare providers. And you inform your healthcare provider about that advanced care planning conversation. Know that the most recently dated document is the directive that's followed. So these are ongoing conversations, and how you feel about your health care now will probably change 20 years from now. So it's okay to keep these updated and change them over time. I have one last question for all of you. What services can provide the most home care support? It's quiet. C. Okay, answer is C, home hospice. When we were preparing for this talk, we recognize that Dr. Kuttner mentions hospice care, but we don't really describe exactly what it is or necessarily when to know when to access it. So I'm going to spend the next few minutes talking about that. So it said, hospice care becomes appropriate when a physician says if this disease follows its natural trajectory, there could be 6 months or less of life. But hospice is a benefit that's available to someone as long as they qualify for it. And I've known people to be on hospice care for years. Okay. The philosophy is to focus on quality of life and not necessarily quantity. The goal is to maximize each day to bring as much services to you and focus on your comfort and not have life-prolonging interventions. Hospice is regulated by Medicare, which means it looks the same across all United States. So if you are on hospice, you're going to get a team assigned to you, and that consists of a nurse that comes out to make sure that you're feeling okay. It adjusts medication. It answers questions. A certified nurse's aide, which is there to give you hygiene care, bed baths, give you that dignity you deserve. There's a social worker and a chaplain for resources and support. Any medical equipment you may need, like a hospital bed or a wheelchair, that's provided, as well as the medications that help you feel comfortable. Beautiful thing about hospice is it's available 24/7, meaning you have your loved one at home and something doesn't seem right or you have a question. Nights, weekends, you pick up the phone, you talk to a live nurse. And if need be, they'll send a nurse out to see you right then and there. I say that and think it's great, but I want to be clear that hospice is not physically in your home 24/7. They're just available 24/7. Hospice can occur in a few different locations. It can be in your home, it can be in a nursing home, and if you medically qualify, it can be in an inpatient hospice care center. And hospice will provide bereavement services up to 13 months for your family after you've passed away. The philosophy of hospice is all about how to support you and your family as a piece of you. And so that's why they're there. And hospice is paid for at 100% by almost every insurance. Okay. So when is it time to consider hospice? I think a lot of people think that it becomes obvious when they're ready for hospice, but from my experience, it's not always that clear. I usually tell my patients that doctors tend to match the information they provide based on the questions that they're asked. Meaning, if you like direct and specific information, ask for it. If you want to think that maybe hospice might be an interest to you down the road, let them know about your advanced care planning conversations. Let them understand where you're coming from and that it's okay to have this dialogue. A lot of times I think people start to think about hospice if they've experienced repeated hospitalizations, they've been given a terminal illness, if the life-prolonging interventions are becoming more burdensome than they are beneficial, and if you're preferring to focus on quality of life over quantity. Talk to your doctor and let him know. This is the way that they can let you know if you're getting close to crossing the line in the sand, okay? And by having these advanced care planning conversations, you and your family are going to be more aware if hospice is something you're ever going to want to pursue and when to pursue it. So I keep telling you to have these conversations, and I want to make sure you guys know that we gave you resources on how to facilitate this dialogue. They're part of your handout as well. There's a few different websites that we recommend. The Conversation Project is a great website where it actually gives you starter kits on how to facilitate this dialogue with your loved ones. Get Your Stuff Together is where you can get a collection of lists on how to gather your personal affairs and make sure you've checked everything in your boxes. Aging with Dignity is how you can order more 5 wishes. The Colorado Advanced Directive website is where you can learn about the Colorado state laws as well as download another medical power of attorney form. And then the Get Directives is actually an online storage system of how you can upload your completed directives, carry around a business card, and it can be accessed wherever you are. So there's a lot of great resources out there, and I hope that you guys are now feeling empowered, educated, and motivated to do all your advanced directives, but at least not all of them, medical power of attorney. Okay? Thank you.
Are you feeling empowered? Good. That's the intent. Our final presenter, and I might add that afterwards we will have our speakers up here to do a little Q&A as well, and then we have a very, very special treat a little bit later at the very end. Our next presenter and final presenter is Dr. Ben Brewer, whose topic, Who Takes Care of the Caregiver, will likely resonate with many of us here who by choice or circumstance or birth order finds ourselves in this very important role. Dr. Brewer is the Director of Clinical Psychology and Counseling for the Department of Hematology and is an assistant professor at the University of Colorado right here at the Anschutz Medical Campus. While Dr. Brewer will be sharing some of the research surrounding caregiving, most of his work is directly working with families of people being treated for cancer. He is one of those wonderfully rare practitioners who also enjoys a little research on the side. And he balances both worlds very well. Please help me welcome Dr. Ben Brewer. Good to go.
Okay, so I'm going to talk to you a little bit about the stresses that caregivers face and how we can help make those better, and a little bit of research that we're doing in that area also. So how many of you... I think you're still muted. Oh, I think it might be. Can you hear me now? Okay, thank you. So I wanted to get a sense of how many of you are in a caregiving role. So I put up here the definition of how we nationally define caregivers. And it's someone who provides any unpaid care to a relative or friend 18 years or older to help them take care of themselves, so pretty simple. Or if somebody's 18 or younger and they have a special medical condition or a behavioral condition or a disability and you're helping with their care. Could everybody that's in one of those roles or has been in their life raise their hand if they feel comfortable? Okay, a lot of you. All right. How many people are in that kind of a situation where you're caring for somebody now? Okay. And if you're one of the few people that didn't raise your hands, I'd like you to imagine that this could happen to you at almost any time in your life. I see people every day in my clinical work that thought that everybody was healthy, and suddenly someone develops a diagnosis of leukemia or lymphoma or a different cancer, and suddenly they need caregiving, and their family has to relocate, often from different parts of the country, in order to be their caregiver. So I want to, for those of you that raised your hands, you're in very good company. About 18% of people in the United States are currently caregiving for somebody. So that's about 43.5 million people doing unpaid work for members of their family and helping them in caregiving. 60 to 66% of these are female. Every time we do the survey, men do a little bit more of the work, but it's still largely female. Hispanic families have the highest rate of caregiving at 21%, and white families have the lowest, with the other groups stratifying in between. The average age of a caregiver is 49, and as Jean referenced, adult daughters do a lion's share of the caregiving, with the most common situation being adult children caring for parents or step-parents. So the economic impact of caregiving is enormous. If we were to take all the caregivers in the United States currently doing work and to pay them a salary that matches what they're doing, that total number for the United States in 1 year would be $450 billion. So this is 2009 data also, and as the baby boomers start to go through, this number will probably increase. So this is, I like to put big numbers in some context, so I looked up, and this number is similar to the gross domestic product of Belgium. It is higher than the GDP of 170 countries on Earth, and by itself it ranks about 25th, along with GDP, so matching Belgium, essentially. It also approaches federal Medicare spending, which gives you a sense of how much we spend on Medicare every year. And then 61% of caregivers understandably report that their role, all this work that they're doing, affects their other job. So they experience time off, missed work, and often they have to retire early. So we know that caregiving is stressful, and a lot of this research has been done in the caregivers of Alzheimer's patients, and increasingly is being done in caregivers of cancer patients and other like heart disease patients also. So we know caregivers experience greater stress than the average person, that they're often more emotionally distressed than the person they're caring for. So a lot of my patients tell me, I think this is harder on my daughter or my wife or my husband than it is on me. And I think there's really some truth to that. Even though our patients go through these incredibly difficult things and often have life-threatening illnesses, I think it's still very hard to care for somebody. There's just a lot of things that make it extra challenging. One of those things is that about 50% of caregivers report a choice, which means that half kind of got drafted into the situation. So this white box is from a survey that was done in about 1,200 people in the United States. And they simply asked them this one question. This is just part of a larger survey. And they asked them, how stressed are you? And it's a Likert scale from 1 to 5. And 38% of people said that they were either a 4 or a 5 on that scale, so that they were highly stressed. You can see these boxes down on the end here. Break it out by hours per week they spent caregiving. So 0 to 20, 34% said a 4 or 5. And if you were caregiving more than 21 hours a week, and you'll note that 416 people were in that position out of the survey, 46% of those people were highly stressed. So caregiving has other psychological impacts in addition to stress. We know that between 18 and 58% of caregivers, those are different studies causing that range to be pretty big, experience clinically significant depression. So we hear this word clinically significant thrown around a lot. In this case, we're talking about symptoms of major depressive disorder, which is severe depression, not just like a few down days here and there, but really a really life-limiting problem. Could be associated with suicidal ideation, low energy, difficulty eating and sleeping, difficulty doing what you want to do with your life. Female caregivers report higher levels of distress and a higher burden due to caregiving than men do. They also have less self-esteem. And so we know that women in general are slightly more likely to develop major depressive disorder or anxiety disorders. But this is far beyond that. And so they've done some research to try to figure out why this happens. And they think that it's due to gender role socialization. This is the leading theory, anyway. And that's the idea that women are often seen as Jean said, it's adult daughters that do a lot of the caregiving. Women are often seen as that they're supposed to do that caregiving role. And so they don't get the sort of extra credit that men get when they step into that role. And so we see this a little bit in parenting too, I think, still. So this is changing, and obviously it's a generalization across cultures. But we think that filling the expected family role is, it doesn't really give you that extra credit. And you sort of have these other roles that your family expects you to do too. And so we think that's why it might be harder on women. So there are a lot of health impacts to caregiving. We talk about allostatic load, which is sort of the stress on a person when they're dealing with something. And high levels of allostatic load result in chronic stress that has negative impacts on the body. So we're all built for short-term stress. If you have a rough week at work, a near-miss car accident, we have a fight or flight response that gets going. And if that gets turned down again and everything's okay and you can relax and recharge, the body is very well designed to deal with that. But when stress doesn't end, when it keeps going, we end up with health problems, and the body eventually kind of breaks down after being keyed up for so long. So caregivers show reduced cellular immunity. So they used the flu shot to study this. So they gave people a flu shot and looked at how good the immune response was to the flu shot. And we found that when people are in a caregiving role, that their immune response isn't as good. They also have slower wound healing, elevated markers of inflammation and cellular aging, an increased risk of stroke, and heart disease also. 1 year of being a caregiver doubles your hypertension risk. So hypertension is high blood pressure that's chronic and quite dangerous over time if it's really up there, which I find remarkable. Just 1 year of caregiving does that. Caregivers who report high levels of role strain, so like the 4s and 5s on that survey that I showed you, have an increased all-cause mortality. So they're more likely to die, even when other factors are accounted for. This was actually a very well-done study that controlled for the things that you would think might explain away that cause. Sorry, my screen just went dark. Let me go on to the next, there we go. So what do we do to help manage the stress for caregivers? So there are, when I meet with caregivers, I like to divide things into either controllable situations or uncontrollable situations. So an example for a controllable situation would be, my patient's really having trouble organizing his medications, and I'm not sure what to do about that. That's a solvable problem. We can get some resources to help with that. We can solve that with maybe a family meeting or education. There's something we can do about that. But an uncontrollable situation would be, I'm really depressed because my loved one has a very serious disease like leukemia and is dying of that. So we can do as good treatment as we can do, but beyond that, it's an unsolvable problem, and that's generally sort of like an emotional problem. So we treat these in different ways. As I referenced, problem-focused coping is solving problems, essentially. So you do goal setting, look at how to make a plan to solve the problem. Emotional-focused coping, we tend to use more therapy tricks, which I'm going to talk to you a little bit more about in just a minute. So it's important to match the coping strategy with the type of situation. So caring for the self while caring for others is a big challenge for everybody. Caregivers are busy. The ones I meet are very overwhelmed. They're highly stressed. They have feelings of guilt or worry when they leave their loved one that they're caring for to go take care of themselves. And so it's hard for them to leave. For years, I've put together caregiving programs for people, and they're some of the lowest attended programming that we offer because it's very hard to get them to leave what they're doing. They always say, well, I'd love to come. It sounds amazing, but I'm so busy that I can't come. So I think, although it's very difficult, it's really important to care for yourself before you care for others. It's maybe a little bit trite, but the oxygen mask warning that they tell you when you get on an airplane to put your oxygen mask on before helping others with theirs, I think is really key, because it's no good if you pass out before you can help other people. And that's really true with caregiving also. So I've included in your packet of handouts that you have a caregiver self-assessment, which is a little self-scoring tool that you can do if you're a caregiver and you're under stress. That was produced by the AMA, and I think it's helpful to look at. You can kind of see where you score. And then if you do score in an elevated range, we have a handout with some caregiver resources and some respite care resources that will actually come and relieve you from caregiving for a little bit of time, which could be really valuable. So what do we know works to reduce role strain? So I'm a psychologist, and obviously I could go into a lot about psychotherapy and all of that, but I want to talk about some just basic coping things that we can help people do. So the first one is boundaries. I spend a lot of my time with caregivers helping them kind of get up the gumption to set limits with people in their family that maybe don't want to have limits set with them, to talk openly and honestly about how they're really feeling. Often caregivers tend to be highly functional people in a family, and so therefore they end up with a lot of responsibility on their shoulders, and helping them delegate that responsibility is really important. So maintaining a schedule and routine, my caregivers tell me that this is one of the most helpful interventions. If you know that every Tuesday you're going to go meet with a friend and have coffee, it makes Saturday, Sunday, and Monday leading up to that a little bit better because you know you're going to get a break coming up. We do a lot for stress and mood problems, and I could talk a lot more about this. But we do a lot of education. A lot of people, it's sort of like if you know the frog in hot water or in boiling water metaphor. If you've been dealing with a situation for a long time, you kind of don't notice how stressed you are or how depressed you are. And you want to identify that before it becomes a big problem. We have simple tricks that we teach, and I would actually teach them to you tonight, except we don't really have time. Things like diaphragmatic breathing, progressive muscle relaxation, and guided imagery are great for in-the-moment stresses. There are some more in-depth strategies to handle unhelpful thoughts. If you have worry about your person that you're taking care of, we use a little bit of cognitive behavioral therapy, and I'm going to talk to you about some research on that in just a minute. And then we use a little bit of mindfulness, which is essentially allowing you to stay in the present moment and focus on that instead of letting your thoughts run forward to the future. And it also helps you not judge the thoughts that come up and kind of let them pass through you. It sounds a little bit Buddhist or a little bit Zen, and it actually was directly borrowed from that tradition. Communication problems are also very common, and I end up doing a lot of whole family therapy and couples therapy as well as communication skills training. So we've done a little bit of research into caregiving role strain, and bone marrow transplant is actually an ideal place to study this because, for those of you that don't know, bone marrow transplant is a very aggressive procedure for treating blood cancers and some other diseases also, where in some cases, if your immune system wasn't working to fight off the cancer, we actually transplant somebody else's immune system through their blood system into your body. And it sounds a little bit science fiction, and it is quite a big procedure to go through. So before every transplant, we actually sit down with families and do a pre-transplant evaluation to make sure that the transplant won't make their life worse instead of better. We want it to make it better. We also, as part of that, identify a caregiver that will stay with the patient for 2 months after they get out of the hospital. And we have patients from 13 states that come and see us, and so people are often relocating for a significant chunk of time. So we know that our caregivers are highly stressed, but we're able to identify them up front, and we wanted to see if we could protect them from that stress that they're going to encounter. So this was actually a study initially done 5 years ago at a different hospital, although organized from this campus. The principal investigator was Mark Laudenschlager, and I helped out a little bit with recruiting. I was a postdoc at the other hospital at that time. And we recruited 148 patient caregiver dyads into one of 2 groups. So one group received normal treatment, which did everything like we normally do for them, and the other group received an 8-session sit-down intervention focused on stress management. And that intervention included these 8 sessions. So we gave them kind of an overview and talked about stress management, the impact of stress on physical and emotional health, a little bit of what I've talked to you here tonight about, how thoughts and emotions lead to stress, coping skills training, management of fatigue, how to keep your sleep together, and other health behaviors. And then also addressing lack of control, uncertainty and fear, communication and social support. So that was our intervention. It occurred after the transplant had started. And this was the impact of that intervention. This was just recently published in 2015 in the Journal of Bone Marrow Transplant. And you can see, so this is one of the measures that we used to evaluate stress in our caregivers. It's called the Perceived Stress Scale, or the PSS. And those, those scores are over here. The average on the PSS, if we were to give it to average people around the world, they would score here. So that's the gray bar. So you can tell at baseline, everybody's quite stressed. And this is before we had done anything. And actually, we only started the intervention about here. In this graph, the blue line is our intervention group. So those are the people we treated. And everybody else got treatment as usual. And so since the intervention started about here, and this is months out from transplant, so the last time point here at 3 months, you can see that our intervention group was much less stressed than the treatment as usual group, and that they were protected from all that additional wear and tear on their body through stress. Same thing for depression was true. In this case, the gray line is actually the clinical cutoff for that major depressive disorder or clinically significant depression that I was talking about. So it's 16 in this case, and that's pretty severe depression. We actually use this at our pre-transplant eval also. And not that many people actually score a 16 up front, but then at the, then you can see that we really improved their functioning over time. So, and the CESD is a commonly used measure of depression. So based on the sort of success of that initial intervention, we got another grant and are doing another study now that's funded by PCORI, which is the Patient-Centered Outcomes Research Institute. It's a $2 million grant that was, again, achieved by Dr. Mark Laudenschlager. I'm a co-investigator on this project, and I think it's a really exciting project. We expanded the number of sites, so we're now also using our own hospital here, in addition to the other hospital that we started with. And we're hoping to catch a more diverse population to see if it's still as effective with people that are in different demographic groups. And then we're changing our outcomes a little bit. So we're going to look at patient quality of life as one of our primary outcomes. We're seeing if we help the caregivers, do their patients report better quality of life? And my patients routinely tell me that one of their primary concerns is their caregivers' well-being. And husbands and wives are worried about their partner and how they're doing with the caregiving role. And so we're wondering if we can improve quality of life in that way. We're also going to be checking in on the caregivers again and looking for depression, stress, and anxiety levels in them. We're also looking at some biomarkers to see if we can protect them from the physical effects of stress using our intervention. So this is a little bit of a complicated slide. This picture is of Dr. Elizabeth Blackburn, who's at UCSF, and we're actually working with her on our study. She won the Nobel Prize in 2009 for medicine for discovering telomerase, which I'm going to tell you a little bit more about. Sorry, I'm not very good at my clicker. Here we go. So telomerase is one of the things that we're looking at. So to talk about telomerase, I want to talk to you a little bit about telomeres. So this is a picture. These numbered things it's actually called a karyotype, but they're just simply your chromosomes in an average cell organized by length. And you can see the X and Y chromosomes on the end there. Some of you might be familiar with this from high school biology. That's where I learned about it. So the ends of these chromosomes, they found out, have little repeating sequences of DNA that act a little bit like the plastic bits on the end of your shoelaces. So every time the cell divides, all that DNA and all those chromosomes have to be copied. And it turns out that copying eats up a little bit of the ends of the chromosomes. And telomeres are there to protect them, just like the ends of your shoelaces are there to protect your shoelaces so they don't fray when you tie and untie them again. And so those telomeres get a little bit shorter with each cell division. And they knew that they were rebuilt by something, and Elizabeth Blackburn figured out that it was telomerase, which is an enzyme that just helps those things rebuild. And she was actually studying pond scum, this little protozoan, and found it in that creature. But it turns out it's conserved over many living things. And so that level is really important. And what we're trying to see with our intervention is if we can allow, because that rebuilds telomeres, if we can keep our caregivers' telomeres a little bit longer, because stress has been found to shorten telomere length over time. And when they get too short, cells aren't able to divide, and we think that that causes health problems in the body. There's a lot of other things that also cause health problems, but that's one of them. So I hope I've explained that clearly enough. There's a lot of complexity there. I want to change gears a little bit and talk to you about a concept called post-traumatic growth. So you've probably heard about the literature and the concept of post-traumatic stress disorder, which is often referenced in combat situations or other difficult life circumstances. And what we found in the literature from post-traumatic stress disorder is that, yes, there were awful things to go through and people were not happy that they had post-traumatic stress disorder, but many of them reported that they got small good things that they wouldn't have gotten if they hadn't gone through the difficult life event. And these have been termed post-traumatic growth. So it's more than just mere resilience. It's actually getting something new you wouldn't have gotten if the sort of bad thing didn't happen. Does that make sense? Okay. So my caregivers often report instances of these, and my patients do also. It's actually a little bit bigger of an effect in patients, and it's a bit smaller in caregivers. But they often report deeper appreciation for life. This is at a 1-year evaluation when I see them after transplant. New strengths and skills, greater compassion and empathy. They often report more ability for patience, greater connection in relationships. That's a big one. A lot of couples say, we were close before, but this really brought us closer together, even though it's been really hard. Deepened faith and meaning in life, and then a restructuring of values and priorities are pretty common. So I want to, and we're almost finished, but I want to give you a little summary of the research on how to facilitate this growth, and it also matches my clinical experience. So looking for ways to make meaning out of your experience is a way to sort of facilitate this and make it a little better. Reducing stress is actually the biggest single factor in the research on people that develop increased levels of post-traumatic growth are able to reduce their stress more, and that seems to allow this process to happen. Maintaining sleep, exercise, and eating is part of reducing stress. Social support is important, but if you have enough, it wasn't a very big factor for people, but it's still important. And then taking time for reflection. Journaling has been shown to be very helpful for people. Doing that every day and writing down how you're feeling and things about your feelings seems to be the most important part of that. And then connecting with others in a caregiving role through support groups. And there are actually resources for support groups in one of the handouts in your packet also. And that's all I have. Thank you.
Thank you, Dr. Brewer. And now I'm going to ask our 3 presenters to come up and have a seat up here. We're going to open it up for some Q&A. If you have a particular question, you can just simply raise your hand and we'll walk around. There's a microphone or 2 floating around. If you don't feel comfortable asking your question out loud in your packets, there's a little notebook and you could feel free to write your question down and then hand that to someone, and then we'll bring it up and read it from here. Does that sound good? All right, well, let's open it up. There are some questions. I think Ann Kirschmeyer, you're in the back there.
So thank you. That was really illuminating and interesting. But one of the slides that Erin showed had a lot of resources that I don't see in the packet. So where do we get those?
I actually looked through your packet to make sure you have them. They are there. They're attached to the additions of the caregiver resources. It's at the tail end of that second page. So hopefully you can find them there. But I did double check.
You could look for those, and if you can't find them, you got it?
Okay.
Great.
Glad you found them.
Great. And the mic is coming your way here.
Hi, thank you. I have 2 questions. I have 80-year-old parents taking care of my 102-year-old grandmother in their home. And what you talked about last is impossible to get my mom to go to any caregiving support. So, and I'm in Colorado, or they're in Michigan. So I've been online a lot trying to find resources, and I'll check out others. But you haven't found anything that really works to make her get up and go. Like you said, they're poorly attended by caregivers.
It's really hard, yeah.
So I just went out there last weekend to try to help, and even with me there, she didn't want to go anywhere. She wanted to stay home. So we're struggling with that, because this morning my 102-year-old grandmother fell, fractured her shoulder, and has a black eye now. So it's very stressful for me out here, and I'm looking for other things. And the other question was, can old age alone qualify you for hospice? So before she fell, my 102-year-old grandmother physically is doing great, but my parents, it is burdening for them because they're watching her all the time.
Take caregiving.
I can take the first question. So it's very hard. I mean, I struggle with this a lot, and a lot of family members come to me and say, my loved one's in a caregiving role, and how do I get them to get help, because they're just burning out. And I think recommending that they take that structure, and even just trying to have somebody cover for like an afternoon, and not to go get a support group or anything, because that's kind of involved. But even just to go for a walk outside sometimes can be a big thing. And starting small, a daily walk is not a bad recommendation. I also think, you're kind of also in a caregiving role, even though you're sort of one step removed from the immediacy of it. And I think taking care of yourself about that stress is also really important. And yeah, obviously you came here tonight, so that's a good start. Yeah.
So I'll take the hospice question. No, old age itself does not qualify somebody for hospice. That said, there could be other resources that would be available depending on where she is, and there could be the possibility of having palliative care, again, depending on where she is, home-based palliative care. And it's somebody who's 102, Erin mentioned the question of, would I be surprised if she died in 6 months? You probably wouldn't be surprised, right? You hate to say that. So it also may depend on working with a local hospice. Different hospices have different approaches to it, but I would at first look for palliative care for her, for that area, wherever she is. And if you need help linking with resources, I know lots of folks in Michigan too, so let me know. Anything
Okay, next question. Thank you very much for this presentation. It was very enlightening. My question has to do with diversity and demographics. My parents are primarily Spanish speakers, and they're in their 80s. And much like the role-playing session that we had at the beginning, the pride and the independence is something that's very important. And looking for resources that are available in Spanish and things that would work culturally for our family. So for example, like journaling in a notebook for my dad would never happen. So do you have some resources for Spanish-speaking families, both like for me and my sister, to help my parents, as well as for my dad who's taking care of my mom? Thanks.
So Your Right to Make Healthcare Decisions, that blue booklet, comes in Spanish, and that provides more information if you're flipping through those first few pages, kind of talking about life-prolonging treatments or interventions, just to kind of explain a little bit more. So that could be one resource for that. Depending on where your parents are, depending in the community in Denver, we do have some palliative care and hospice teams that, when it is appropriate, are Spanish speaking. That's unfortunately kind of the only other language besides English that I've found where we have a whole team that speaks that language, but that does exist. So know that that's available as well. And I think lifting up, you know, just to, if they are open to having other caregivers, lifting up what is important in your family and what culturally fits for your specific family. Because I think that we don't ever want to assume, but we also want to be very respectful of what fits for you specifically. And so don't be shy to say, my dad would never want to be taken care of by another man or by another woman. That's completely okay. That's very appropriate. And these teams are expecting that and know that, and they work with that. So please lift up what fits your specific family. Do you have anything to add?
Five Wishes is in Spanish.
Five Wishes is also available in Spanish. Yeah, thank you.
Yeah, as far as you know, culturally fitting interventions, there are individual therapists in the community that do, and a lot of them are social workers that are bilingual or Spanish only, and some of them do this work also. But you'd have to kind of go to them in many cases, and it's often a question of, would your parents go in that direction? And that's often not a culturally fitting thing. If they got there, they might find that it was culturally congruent, but going to the office might be a challenge. I find that a lot when I refer Latino and Hispanic families out. I personally work with an interpreter, and I find it's kind of challenging if the families are here. It takes, of course, twice as long because everything has to be translated, but it's worth doing. And I find that patients, if they're willing to sort of take a double appointment time to do that and to come in, it really does work. And I wish I spoke Spanish, but I don't. So I think it can work. It's just challenging.
Next question.
How busy are you in terms of patient load? Are you fully busy? Could somebody always get your help if they need it? Is there room in our program for more people?
Who are you asking, Judy? Ben, specifically?
All three of you. You're a team. Jean, start with you.
Cool. Well, we can go across. So we, like I said, we have Judy's question of how busy are we? Is there room for more? Yes, we'll see everybody. So here in the hospital, when we're on the palliative care service, we've seen year-over-year growth, both in the number of patients that we see every year. I think almost every month, huh, Harry? We break a new record. So we've also been fortunate to have year-over-year increase in support from the hospital as we grow our service to meet those needs. So we've increased the number of physicians, the number of advanced practice providers, addition of our full-time social worker, yay, full-time chaplain, and our volunteers. So we've seen that growth. And then in our outpatient clinics, we are, both our neurology palliative care clinic and our cancer center-based palliative care clinic have added time and people as growth has occurred. And actually the team doesn't even know this yet. I actually just got a directive today from our health system CEO to come to her with a proposal to grow palliative care across all of UC Health, because she wants it to be a key thing that we offer as UC Health across our whole system. So we are in a growth business, shall we say.
We have a similar story in oncology. So my psychology team has grown a lot. There's 2 of us in BMT, and we just hired 2 new psychologists to add to the one we already had in medical oncology. So I think psychology is really well covered. And then, of course, our social workers do a lot of therapy also. And we just got permission to hire 3 more. So we're very excited about the growth of that. We don't have a waiting list right now. There is currently a short waiting list in medical oncology, but those 2 new psychologists will go in and hopefully help reduce that quickly.
Wonderful, thank you. Next question.
Hi, I actually have 3 quick questions. The first one's for Dr. Ben, and the question is, what if the caregiver already suffers from major depressive disorder, it has a history of PTSD and anxiety? What should they do to, I guess, work with that, knowing that that's in their background and that they still have to take care of something?
That's actually quite common. About 20% of people have a major mental health diagnosis just in the world. And those are very varied. So it's like planning for an additional stressor. What do you do to protect them from that? So hopefully they've already been in treatment for some of those things. If not, I would start that. If they were coming to see me, we would do, kind of like weekly follow-ups for the whole duration of caregiving would be the plan. If you were in a setting where you needed to be referred somewhere, there are actually pretty good community mental health resources, at least in the metro area. And setting up that and keying that therapist in with the person's medical team that they're going to be caregiving for so that they can communicate, I think is really important. So that all the parties can talk and get signed releases so they can all communicate. Because then when health changes happen to the person that the caregiver is caring for, they can be prepared for in therapy. So if you know that additional stresses are coming, or if the person might pass away at some point, it's very important to prepare for those things. There are certain caregivers that we really try to get extra help from the rest of the family for also. And often we'll say that maybe it's okay that you help out, but we don't want you to be the primary caregiver. And there's varying levels of depression and post-traumatic stress disorder, and that the sort of devil's in the details. But that's what we do at pre-transplant eval anyway.
Okay. So the second question is, so I have little kiddos. Actually, Sarah's 13, but they go down to 6, age 6, I should say. And my mom is getting to this point where she's pretty sick. So what should be, is it okay to have them around if we get to this point, or would it be better to not have them around, or can you guys give me some advice on that?
So your kids will lead the way. I really do think that they'll let you know if you ask them, how much do you want to know? How much do you want to be involved? Are you okay coming to see grandma? If they're not okay, that's okay. I think what we see is the scariest factor for children is probably the scariest factor for all of us is the unknown. Coming home from school and not knowing how grandma's going to be that day and not knowing what to expect. And so not talking about it is scarier. So not letting kids know, grandma had a harder day today. She's just going to rest this afternoon. More questions are being asked, great, but let them lead the way on how much description and detail they want to know. But if you're going down to your 6-year-old, concrete, accurate language is important. Okay. Saying, grandma went to sleep or grandma, went away for a while, if there is a death, can lead to fears of sleeping and to going away. And so it's really important to use accurate language. It can be simple, it doesn't need to be detailed, but it should be pretty honest.
Thank you.
What do you want to
and
add to
the
that?
last question, is it ever appropriate, and I don't even know if legally we can force my mom to go into assisted living or caregiving, is it ever appropriate to do that to a parent? I mean, it's like, I can barely take her dignity away, and she's very stubborn, and she's very this is the way I want to do it, and I'm going to stay in my home, even though she can't cook for herself, even though a lot of times she spends many, many, many hours of the day in bed. And there's nobody there with her, and she doesn't want anybody there. It makes it very difficult. How do you handle something like this?
That's hard. That's a really hard situation. I think you want to balance that she has the right to express her own opinion and her do what she's wanting, but I think there's the reality that she's needing more support, and that's causing a lot more stress on the loved ones around her. So I think, we would probably initially approach it as lifting up what is she worried about and what is she hoping for, to really find out what is the fear of maybe going to a more supported environment and getting more to the, not just that she's saying no, but what's behind that piece. And then also making sure that she's assessing and is really competent to be making these decisions. When we're talking to patients and we want to make sure that they're understanding their situation, we want them to repeat back to us, what's the benefit of this treatment? What are the risks of it? And what are the burdens? And if someone can show me that they understand the full perspective and situation, so what are the risks of being at home alone? what are the benefits of being home alone and what are the burdens, she can understand that, then she has the right to make these decisions. She's starting to not be able to piece this together and put the situation together. That's when medical power of attorney becomes very helpful. That's when having a living will comes helpful, because a lot of times you've appointed someone to say, if I get to the point where I need help in placement or increased care, you're legally given that right to help advocate for that. So it starts to become a grayer line, but you do have legal support when someone starts to lose the capacity to make safe decisions for themselves.
Our next question.
I'm thrilled that palliative care and hospice care are growing and doing as well as they are in Colorado. I look forward to that. I also have a question about how palliative care and hospice care might change if the right to die legislation gets passed in Colorado. I personally believe very strongly in the right to die opportunities, and I hope it will come to Colorado, but I'm curious how it would affect that care delivery system. And do you know anything about how it operates in Oregon, where that is legislated?
The answer of yes, there's good data from Oregon that actually hospice and palliative care have gotten much stronger in Oregon since they passed their legislation, which is, of course, a number of years ago now, and that there's actually increased access to palliative care, to hospice care, to make sure that people are getting all the support that they need. And I think that would be the hope, that we are able to continue to provide all the support to maximize people's quality of life, so that if they are making that decision, that they do have their own quality of life maximized to the extent possible at the time they're making that decision. I think there was somebody over here, right? Yeah.
Like everybody else, I'm just really grateful for your presentation. It's so very helpful and much less dreary than I expected. It somehow is burden lifting as opposed to burden inducing. So thank you. Simple question. Can we only appoint one person to be in charge of our medical care? Can we appoint 2 adult children or something?
You can have more, and on that form it actually gives you an option for a primary and then 2 alternatives. I do recommend that you list one person first. It does not exclude the fact that you as a family make decisions together. But when you have listed all 7 of your children as your primary, it means all 7 children have to agree and be available in all of the criteria I listed. And so it makes it harder. And so again, it's not the child you love the most, it's just maybe the one that's the most available or accessible. It does not exclude anyone else. But I do recommend having an alternative. It's very good to have a backup plan, for sure.
Question over here.
Yes, I don't know if you covered this, but how does the palliative care team get referred to patients? And are the patients briefed on the purpose of palliative care before the team goes to see a new patient?
So it depends a little bit on the setting. If the question is here in the hospital for a hospitalized patient, it is a referral from the primary treating physician. Anybody can call us, even the family members. Sometimes we get a call that says that this is a patient who could use your services, may need palliative care. That said, out of respect for our professional colleagues, we always contact the primary treating physician to make sure that it is okay that we go see their patient, because we work together as colleagues. I think as a little side note, I think what's been interesting over time, and I'll be interested to hear Harry's perspective on it, I think we've seen more and more over time, and it's reflected in the hands that were raised at the beginning of, when we always ask, well, what is the reason for the consult? And the reason being, well, the patient or family asked for you. or asked for palliative care, and showing that there's more interest in it. In the outpatient setting, say for one of our clinics, that again would be a referral from either your primary care doctor or your primary treating physician, a referral to that clinic. And then for home-based palliative care also then would be a referral. So working through whoever your primary treating clinician is. Oh, and then the brief beforehand sometimes not. We never know what we're walking into. So we never make any assumptions. We always walk in, and I think the role play actually showed that nicely. We introduce ourselves, we explain what it is, what we do, and is this a good time? May we spend time with you? And go from there.
Any other questions?
I have one question from the audience. Would a will made in one state be honored in another state?
Yes, it definitely should be. If you are relocating and know that you're going to be moving to a new state, I think it's important to look into those states' laws and what they require. But yes, when we have patients that come here from all over, and if they have completed a form of advance directive, we follow that.
Are there very many resources available for palliative care for developmentally disabled adults, particularly those who are likely on Medicare or Medicaid?
So palliative care is available independent of the So palliative care would be available independent of the diagnosis. So if there was a developmentally disabled adult who had a serious illness, absolutely. And yes, we can bill to Medicare or Medicaid for our services. Does that actually answer your? Specific to the developmentally disabled? Not that I know of, Erin. Not that I know of.
It's a good question. I'm not aware of a specific group.
Question up in the back.
Sorry, I'm sneezing. I'm a geriatric nurse, and I've done this for over 30 years. When I bring up the term palliative care, I've done it myself as a home-based service, but people become fearful of the word palliative, assuming that, it's they're dying. Has there been any movement to change that terminology to make it more user-friendly?
Take that. It's an ongoing debate. I will say once there became board certification for physicians and specialized certifications for nurses, chaplains, and social workers in palliative care. I mean, I am board certified in hospice and palliative medicine. That is not going to change in terms of that. If you look across the country at what different services call themselves, there is variation across the country in what different services call themselves, especially in the pediatric space. If you look at pediatric palliative care services, they will tend to be called things like supportive care and that sort of thing. I will say the name is here to stay. We've basically embraced it and explain it and not shy away from it rather than trying to call it something else when it really is what it is.
One tactic that we use when trying to describe, because hospice is also that word, you said the right. H word. What is very commonly used in our practices, we will lift up, I hear that you're wanting to stay at home and that you're tired of coming back to the hospital. I'm wondering if it sounds like it'd be helpful if a team came to you. And we describe the services about what the team is and how it's supportive and how it's paid for at 100% by your insurance. And people are nodding their head going, oh, that sounds really nice. And then we say, and what I just described is what we call hospice. And it's kind of that back foot in the door that gets you, and so that can also be a helpful tactic for palliative care as well, because it is palliative care. But people hear that word and they kind of tune you out immediately once you start saying that word, despite what services you describe behind it. So if you are trying to advocate for your patients, that might be a way that could be helpful, is to describe why you're recommending it before you say exactly what you've recommended.
I have one other question. I do a lot of advocacy for people, and one of the challenges I have is that a lot of the doctors don't want to consider like home-based palliative care for people with complex chronic health conditions. Can you speak to why that might be so I kind of have a better idea on my side of the fence, or maybe I can improve my communication?
I actually think it's probably the same thing. And, in terms of even on the healthcare provider side of things, there's still a lot of, it's gotten better. It's gotten much better over the last, 5 to 10 years, but there's still a lot of misunderstanding of what palliative care is. So even healthcare providers, hear palliative care, think hospice. So I think some of the same tactics of you're telling me that your patient's failing at home and they're calling you all the time. Here's something that can help you and partner with you, help you make your life easier as their primary care provider or whatever. And as an added service, I think the other thing that's helpful too is that the sort of try it on for size. Try it out. Tell us what you think. Touch base, and let's circle back in a month and see. Is this actually helpful for you? Is it not? My patient actually, Mr. K, who I talked about, had intensive palliative care services when I first met him, and then he was actually doing pretty well, and he actually stopped having palliative care services at home for a while, and then we reinstated them. And you can actually do the same thing with hospice, which a lot of people aren't aware of. You can enroll in hospice, you can then disenroll in hospice, you can re-enroll in hospice. And I think explaining some of that too, that it's not a final decision.
Well, thank you. If there are no other questions.
I'd like to make one comment, David, if you don't mind. Everybody knows somebody who's actively involved in, and often we don't know how to help our friend or someone who's going through this. So you're all ambassadors to teach your friends that these services exist, and these wonderful clinicians are here to help. So help you do something.
Great. Thank you, Kiara. I wanted to take this opportunity to extend gratitude to our presenters, Dr. Kuttner, Aaron Rosenberg, and Dr. Brewer. If we could give them a round of applause. I also wanted to acknowledge our not ready for primetime players, role players from our palliative care team, Harry Brackett and Dr. Jeannie Lee. I want to remind us all that we are in the month of Thanksgiving, and we're grateful to have such competent and wonderful practitioners for palliative care and hospice care when we need it. It's good. It's a good resource. I had the privilege, we've made a lot of friends in this community, I tell you, and some of them are coming up on stage right now, but I had the privilege of listening to Gospel Harmony last Saturday when we attended Celebrating Women's Health. And so here to sing us out for the evening is Gospel Harmony. And I think they just may need a minute to get set up.
Hey!